Good evening, everyone. Good evening. We are going to actually start in 2 minutes. 2 minutes we're going to start, but I did want to kind of let you guys in as people are continuing to join. You are all muted, but when we get to the Q&A, you are able to unmute yourselves to ask your questions.
It ain't showing me.
Please govern your mute accordingly. Good evening, everyone. And I like to first say welcome to another edition of Living Well Brother to Brother Speaker Series. I have the pleasure to be joined by two distinguished guests, both doctors in their own right. Brother Dr. Desmond Sumter, who was our International Health Advisor, and Dr. Vernon Rayford, who is the chair of Sigma Health Committee. Tonight, we're going to be talking about monkeypox and all things related to that. I felt like it was a good topic, especially because it was in the news a lot. Coming out of COVID, it's something that, we want to be trusted messengers at all times when these kind of things come about, right? And so I thought it was critically important that we bring two professionals together to share what their thoughts were so we can kind of get those questions that people may or may not have answered, and also to end that disparities of hesitancy around vaccines and the like, right? So with over 18,000 cases in the US and over 48,000 cases reported and globally, I just thought that it was a great time for us to get in front of the masses and the peoples and the communities that we serve to actually bring about this topic. So again, just a little bit of a housekeeping. We would love to hear any questions that you have, but we're going to save those to the end. We'll have time for the end for any Q&A or any questions that you have. We also would like to know where you're from. So if you have a chapter that you're from, or if you're not part of the D9, but you're just a regular person from the community, love to shout out your state and area that you're at. So if you can drop that in the chat, that'd be awesome for us. So we can go back and understand how many communities that we actually touched in chapters. So without further ado, I'm going to pass this over to Dr. Rayford for his intro.
Thank you, Brother Director Johnson. I want to thank y'all for joining us. I'm just thankful for the opportunity to share a little bit of kind of what some of the things that I think about professionally. I've been fortunate as chair of the health committee to bring professional, kind of the professional touch to the service and signal. And so I'm especially thankful to be joined by Brother Dr. Sumter, who's International Senior Health Advisor. And together, we're going to talk about monkeypox as we know it. So August 28th, we're going to talk about monkeypox as we know it and convey to you, things that we think would be important for you to know about monkeypox. We're fortunate in that we represent different areas. I'm in Mississippi. Brother Dr. Sumter's in South Carolina. Brother Melwan's in Maryland. And so a little different looks. It's good to have a collective conversation. And again, we're going to have questions at the end. Brother Melwan, could you share the slides? So, and I'm not going to, read these objectives, but we hope that by the end of the talk that you'll know a little more about monkeypox, and in particular, kind of what you should know at this point and things that you can do to make sure that you can be as safe as possible. Brother Dr. Sumter will take over as we advance the slide, and I'll let him introduce himself a little more.
Thank you, Dr. Rayford, Brother Rayford, and also Brother Melwan for this opportunity to share information with my brotherhood and others, members of the Divine Nine, as well as our community members and friends about monkeypox. As you have said already, Brother Rayford, it's our goal today to share information, to empower people with knowledge about this virus that is emerging in our communities. A lot of people have fears and anxieties surrounding it. And I just believe that if we share with people information about monkeypox and how to prevent the spread of it, we can reduce the level of anxiety that a lot of people may have surrounding this virus. So with that said, we will start with the first set of slides, Brother Melwan. That is up. So I would like to start out by saying that although monkeypox is new to us here in the United States, it is not a new virus to the global community. Unlike COVID-19, that was a novel virus to our communities worldwide, monkeypox, fortunately, is not a new virus. Monkeypox, as you can see in this display, was first discovered in 1958. It was found in monkeys that were kept for research purposes. And because the virus was found within monkeys, it was named monkeypox. And monkeypox was first identified in humans in 1970, when a 9-month-old boy in the Democratic Republic of Congo was diagnosed with the virus. Also during 1970, the monkeypox virus spread to 11 other African countries within the continent of Africa. And since that time, periodically, monkeypox has had outbreaks in Central and Western African countries. So monkeypox is considered a zoonotic virus, meaning that it can be transmitted from animals to humans. So question you might be asking, so when did monkeypox first enter the United States? It wasn't in May of this year, actually it was in 2003, was the first time monkeypox was discovered in the United States. In 2003, it's believed that imported animals from Nigeria that was housed near prairie dogs here in the United States enabled transmission of monkeypox from those mammals from Nigeria to infect prairie dogs here in the United States. Those prairie dogs were then sold to families and institutions here in our country. And once those institutions and families and individuals had these prairie dogs in their possessions, some of these individuals were bitten or their lesions came in contact with humans came in contact with their lesions, and thereby humans in the United States became infected. Approximately 47 individuals in 2003 became infected with monkeypox as a result of that 2003 outbreak here in the United States. So I said all that to say that even though monkeypox is the hot topic right now within the health community, it is not our first encounter with this virus. Now that we're experiencing this outbreak in our community, we're talking about it more. A lot more people are being infected with monkeypox currently during this outbreak than we experienced in 2003. So you might be asking yourself the question, so how did all of this start over the past couple of months? So during my research and speak with Brother Rayford and others, we found that there was an outbreak in Central Africa in March of 2020 of this year. Following that outbreak, numerous European countries also experienced a rise in monkeypox cases, and thereafter we began to experience monkeypox cases here in the United States in May of 2020. To date, approximately 48,000 people worldwide have been diagnosed with monkeypox, and approximately 18,000 individuals in the United States have been diagnosed with monkeypox. Brother Melwan, next slide. And this is just a pictorial display of the spread of monkeypox around the globe. As you can see, there's a concentration of it in Central and Western Africa. You can see the spread of it in the European nations, as well as in the United States and North America, as well as South America too. Brother Melwan, next slide. So monkeypox, as I may have mentioned already, typically is found in Western African countries and Central African countries like the Congo, the Democratic Republic of Congo. However, this current outbreak, monkeypox has been found outside of Central and Western Africa. And as you can see, the majority of the new cases are about 42 to 43,000 of the new cases have been found outside of the areas that we had typically historically found monkeypox. So this virus is spreading in new and unprecedented ways. Next slide, Brother Melwan. And it sounds like someone's volume is not muted. I can hear feedback. I'll continue. Monkeypox is a part of the Poxviridae family of viruses. As you can see in this pictorial view, monkeypox is a fairly large size virus. It's a part of the subclass of Poxviridae family called the orthopox virus. Many of you all may be familiar with smallpox. Smallpox is within the same subclass of Poxviridae virus as monkeypox. So monkeypox and smallpox are classified under the same subtype of the Poxviridae family of viruses. Next slide, Brother Melwan. And as you all may have gathered or could guess, smallpox and monkeypox, because they're part of the same subfamily of viruses, they present in very similar ways. Both present with a person, once they become infected, can have flu-like symptoms and a pus-like or fluid-filled rash. And I won't go into detail about that because Dr. Rayford is going to share greater details about how monkeypox present. But I will share that although monkeypox and smallpox are similar, they're part of the same class of viruses, they do differ in some key ways. Monkeypox, the host or reservoir, the reservoir is typically a small animal, like prairie dogs, etc. But smallpox, the reservoir is typically humans. Smallpox spread between from human to human, whereas monkeypox can spread from animal to humans. The incubation time between smallpox and monkeypox are very similar. Smallpox is up to 19 days, and the incubation period for monkeypox is 5 to 21 days. The duration of symptoms between monkeypox and smallpox is also very similar. Monkeypox can last up to 4 weeks, and smallpox can last up to 5 weeks. However, smallpox and monkeypox differ significantly in terms of their fatality. Smallpox, if you all are familiar with the history of smallpox can cause, in the past, cause up to its death rate range from 30 to 50%, depending upon the strand of smallpox that a person was infected with. Whereas with monkeypox, the death rate can range between like 1 up to 10%, depending upon the strand. The most common strand in the Congo, also classified as the Congo strand or clade 1 strand, that strand, the death rate is up to 10%, whereas the clade 2 strands found in Western Africa, the death rate could be as high as 3%. Next slide, Brother Melwan. As I previously mentioned already, monkeypox is considered a zoonotic virus, meaning that it can spread from animal to humans. And this is just showing some of the different reservoirs that humans have gotten monkeypox from in the past, such as prairie dogs, monkeys, rodents, so forth and so on. All right, so I would transition to how monkeypox is spread to humans, or how monkeypox is spread even among humans. The main way that monkeypox is spread among humans is that it's from direct contact with a rash or bodily fluid from a lesion from a person who's affected with monkeypox, from kissing a person, close contact with the person, so forth and so on. It can also come, a person can also become infected with monkeypox through coming in contact with bodily fluids on fabrics, towels, bedding, clothing, surfaces that have been used by someone with monkeypox that have not been cleaned. Monkeypox can also can be spread through respiratory secretion, but it is believed that you have to be in very close contact with someone, like kissing a person, to get monkeypox through respiratory secretions. Monkeypox can also be spread through oral, anal, and vaginal sex, utilizing shared sex toys. If you come in direct contact with like rubbing someone's rash that they have secondary to monkeypox, so forth and so on. Next slide. In addition to direct contact with a rash by a person who's affected with monkeypox, or coming in contact with contaminated bedding or clothing, etc., a person can also get monkeypox, as I mentioned before, through coming in contact with an infected animal, by being bitten by an animal or scratched by an infected animal. A pregnant female can also pass monkeypox to her unborn fetus through the placenta. Scientists are also researching if a person can spread monkeypox if they have no symptoms, because currently it's believed that if you are experiencing symptoms, if you're experiencing a rash, if you're experiencing upper respiratory-like symptoms, and you're diagnosed with monkeypox, that you are contagious. But scientists are studying if you have no symptoms, and if you happen to test positive for monkeypox, if you can be contagious enough to spread it to someone else. Science is also looking at how often monkeypox is spread through respiratory secretions. And they're currently studying if monkeypox can be spread through semen, vaginal fluid, urine, or feces. So again, just to recap, monkeypox can be spread through direct contact with a person who has a rash, or with bodily fluids from a person with monkeypox, such as fluid from their pustular lesions, or from like kissing a person, or through sexual contact with a person with monkeypox. Next slide. So currently in the United States, the vast majority of persons who have been infected with the monkeypox have been men. They have been men who happen to sleep with other men. So that's the bulk of the people who have been diagnosed with monkeypox here in the United States. The vast majority of persons have also been white. So the vast majority of the persons who are tested positive for monkeypox have been white, male, who sleep with men. But a decent percentage of those individuals are also Black males as well. Next slide. Again, this is just another a diagram, another way of me displaying what I just mentioned, that the vast majority of the cases in the United States thus far have been in men. As you can see, men in this bar graph is shaded in blue, women is shaded in orange, transgender men are shaded in purple, and you can see the graph key there. But as you can see, it's obvious that the vast majority of the cases in the United States thus far have been in men between the ages of like 20 and 50. Next slide. And this is just another way of me showing that the vast majority of cases have been in men, typically white men, but as you can see, Black men is in the like fuchsia color. So Black men or Black individuals are pretty much just as even at this point as of August the 14th of 2020 with white men, and Hispanic men are not that far behind. So the vast majority of cases are typically in males, and currently it's kind of like evenly divided based upon this data between Hispanic males, Black males, and white males. Now I'll turn it over to Brother Rayford. He will present to you how monkeypox present as far as its symptoms and presentations.
Thank you, Brother Dr. Sumter. So in terms of presentation, I want to begin by saying that this kind of spread of monkeypox that we're experiencing right now is different in many ways than the monkeypox that's been described in Central and Western Africa. Amongst those things has been the human-to-human spread, but also the presence or absence of certain symptoms. So previous descriptions of monkeypox had a kind of you come into contact with monkeypox, there's an incubation period. That's the period where the body, the infection is taking hold of the body. That period could be anywhere from 4 days up to a little over a week after exposure to the monkeypox. The previous monkeypox disease would be a prodrome, and what that would be pre-symptoms. They would be fever, chills, headache, and importantly, swollen lymph nodes. And so one important distinction between monkeypox and smallpox, monkeypox, and any of the other common viral diseases that give us rashes has been the presence of swollen lymph nodes. And after this kind of prodrome or kind of pre-rash type symptoms, the appearance of the characteristic rash. And I'll show you some pictures of the different rash, but important to know that it's a rash that changes over time. The rash is often painful, and it's really important for people to understand or to kind of understand if they were at a particular risk And then if they were to develop a new rash, to isolate, so limit exposure to other people, and then reach out to healthcare providers, reach out to their clinicians to start the process of being evaluated for monkeypox. So early on, the symptoms of monkeypox could look like most other things: COVID, fevers, chills, muscle aches, headache, but the enlarged lymph nodes. And so someone who has, someone who's in a risk group who develop these symptoms and they have swollen lymph nodes, again, that's a really, really key finding for people to, stop, to slow down, to isolate, and then reach out to us in healthcare to start the process of being evaluated. And so the symptoms, so once the symptoms begin from beginning to end, symptoms of monkeypox and what we think is the contagious period, that period could last from 2 to 4 weeks. And so with the changing skin rash, people aren't considered, people are still considered contagious as long as there is an active skin rash. So once the skin goes back to its normal state, that's when we believe that people are not contagious. And unfortunately, this period could be up to 4 weeks. And so, this runs the risk of really affecting groups that may already be stigmatized. And so one reason for us to take monkeypox serious and do what we can to prevent the spread is that, if you can imagine having to be off work for 4 weeks. And so having to severely restrict your activities for 4 weeks, you can kind of see where if we don't change the kind of spread or stop the spread, then we may be in for a long time of just recurrent infections with monkeypox. Brother Malwan, next slide. So the rash. And what you see here are many different pictures of the rash. What's important for you to know is it's a rash that changes over time. Oftentimes, the course of the rash is it begins as a spot, an uncomfortable spot, and the rash is often multiple. Begins as an uncomfortable spot. That spot becomes a blister. So a blister is it's kind of a fluid-filled lesion. The fluid is usually clear. That blister becomes a pustule. A pustule is also fluid-filled. It's just the fluid inside is darker and thicker. And then that leads to an open sore. And from the open sore, it goes through a healing phase and ultimately ends when the sore scabs and the new skin appears under the scab. You can see many different views. And so what can be challenging with monkeypox, you see really different appearances across these pictures. And then obviously, depending on skin tone, the rash may not be red. The rash may be more dark. But I will tell you that, in terms of rashes, in medicine, a rash that occurs on the palm of your hands or the sole of your feet, that's a rash that really needs to be checked out. A brand new rash on the palms and soles of the feet is someone who could be at risk. And so I'll take this moment to say, Brother Dr. Sumter presented data describing the experience with monkeypox so far. And that experience has been primarily men. So 98+% have been men. 94+% have been men who have sex with men. But I caution you to understand that's what has been described. And so we may see more community spread and those numbers come down where women and older people make up a larger share. So in terms of it's one of those things that be on the lookout for further data. The CDC, fortunately, every couple of weeks will put out this is what we know so far. These are the people that have been diagnosed so far. And through that, we learn about the changing dynamics of this spread. But the challenge part about this rash, in compared to the previous monkeypox, is in contrast to a widespread rash, a rash that you could easily sleep, like the one on the left side of the screen that's visible on the face. Our experience with this current outbreak of monkeypox has been, the rash has been in the genital area. So the majority of the rashes have been in the genital areas, followed by the face, and then followed by the extremities. And so you may not look at someone and see whether or not they have monkeypox. But what's important to know is you need to have more than casual contact. So riding a subway train, sharing an Uber, with someone with monkeypox, if you're not in contact with their skin lesion, you're unlikely to catch monkeypox. And this prolonged intimate contact, which includes sexual contact. And so, again, the rash is the defining feature of monkeypox. It's just where the rash appears that's been different. There are descriptions now of contacts of people who've had monkeypox who are being found to have evidence of monkeypox, even though they've been minimally symptomatic. Next slide. So again, important to know that this rash changes over time. If you have a rash that's brand new, a rash that's hurting, a rash that's changing over time, isolate and then reach out to us in healthcare so that we can tell you what to do, the next steps. Next slide. And again, the progression from spot to blister, to pustule, to sore, and then ultimately to a healed, scabbed over or wound. And again, these pictures don't really do it justice because unfortunately it focuses in on one spot. And so the lesions are often multiple. It's just, where they appear. So more than just one spot. Down here in Mississippi, we have a lot of mosquito bites. And so that one on the far end to the left is what sometimes mosquito bites or flea bites look like. And so that by itself is not evidence of a monkeypox. Next slide. So in terms of testing, if you know that you've been exposed to monkeypox or you have a new rash, then get tested. Our testing ability is improving. Our early efforts have been hindered by just kind of challenges with testing. Previously, only state health departments or public health providers were able to do the testing. Now testing can happen through some of the commercial labs in the country. But I will tell you that if you are concerned about monkeypox and you would like to be tested, call ahead to your healthcare provider and let them know in terms of, let them know so that they could test you appropriately. Most of the test requires a heads up. We have to tell the lab that we are testing for monkeypox. And so, reach out. If you think that, you've been, exposed, then, and you have the lesions, reach out for testing. Next slide. And usually the test is, we can stay here. Usually the test is a sampling of fluid from the lesions, from the skin lesions. It's not a nose swab. It's a swab of the lesions. The healthcare providers, and so just to kind of let you know right now in terms of, the things that healthcare providers are asked to do if they're going to test, So we're actually asked to be in what's called contact precautions. And so for us, that's a gown, that's a glove. We're also asked to wear an N95 mask as well as eye protection. So gown, glove, eye protection, and N95 mask, not to scare you, but right now those are the precaution recommendations. As we learn more about the ways that this monkeypox is spreading, I anticipate there'll be changes to the protective equipment. But if you're on here and you're in healthcare and you suspect that a patient has monkeypox, the recommended personal protective equipment is gown, gloves, eye protection, N95 mask. That's the recommendation. Fortunately, so earlier, Brother Sumter talked about the similarities to smallpox. That similarity has translated to us having vaccines available for monkeypox because of that, at least from an experimental standpoint, experimental evidence that the monkeypox and smallpox viruses are similar enough that a vaccination for smallpox could be helpful for monkeypox. And so there's one vaccine that was recently approved in 2019. So again, monkeypox is not new. It's not some big conspiracy either. It's not new that there's a vaccine that we can give to people. After they've been exposed. And so it's a strategy because of the long incubation period that if someone reaches out to you and say, hey, you've been exposed to monkeypox, then you have the option to get a vaccine. And that vaccine could reduce your risk of having monkeypox, as well as if you were to develop monkeypox to reduce the severity of the symptoms. Fortunately, monkeypox in this kind of the pandemic that we're seeing here has not been as deadly as monkeypox that's been described in Central Africa. But if you remember the slide where the population has been younger men, and so younger, presumably healthier men. So we worry what those numbers would look like if it can spread to medically complex, particularly older patients. But again, there's a vaccine. Unfortunately, vaccine supply is challenging, and also there's challenges as far as getting the vaccines to the groups that are at the highest risk. And so really working to make sure that the vaccines and the information are going out in a way that's sensitive to, we didn't mention it, but, this monkeypox, the name can be stigmatizing, the disease can be stigmatizing. It affects groups that have been significantly affected by stigma. And so the public health messages, the professional messages have been tempered with attention toward stigma, intentional versus unintentional. The Jynneos vaccine is the preferred vaccine. It's in shorter supply. There's a more widely available vaccine that's an older vaccine against smallpox by itself. It is a more active virus and has more potential side effects, potentially people with immunodeficiency. So if we were to get into a scenario where the outbreak continues and we don't have the preferred vaccine, it could become an option, but as we're learning, stay tuned. I'll also mention, so there are some antiviral therapies that one called TPOXX. It's been shown to be active against smallpox. In people with severe monkeypox, it is being used under the thought that the similarities between smallpox and monkeypox would mean that this would work in people who are most severely affected. Next slide. So I'll wrap this up, and we can open up for questions. But what's the big deal? 48,000 cases. We're well over billions of cases with COVID. There are other viruses going around the community. You know, why should we care? Why should we talk about it? Why should we have a future talk? There's something different about this monkeypox. It's spreading differently. It's spreading well beyond the places that we knew it to spread originally. It has a risk of affecting vulnerable people. There's still a lot we don't know, particularly what happens when it spreads beyond the kind of initial groups. The contagious period, so 2 to 4 weeks, that's a scare. And then from an effective treatment standpoint, you know, effective testing, there's been challenges with testing and then deploying the vaccines. And then we have some brothers, we have a brother who's a veterinarian, and we'd love to bring him on in the future to kind of talk about, you know, when we saw the zoonotic infection where we see infections going from animals to humans, there's a risk that monkeypox could move from humans in the United States to animals in the United States. If that happens and animals in the United States become a reservoir for monkeypox, then we run the risk of having sustained endemic, which means, you know, infection occurs regularly. We run the risk of having endemic monkeypox here. We did not, you know, monkeypox was in the United States in 2003, but they were able to identify the monkeypox and stop spread. And we were able to not hear about monkeypox for, particularly, you know, in large numbers, for another 19 years. And so it's possible, but it's going to take a lot more work to try to break the transmission. And the goal really is to get to zero transmission, because there's a risk for it becoming routine in our environment, especially if we have the human to animal spread. And so going the different directions. So next slide. And with that, next slide. I'll skip over this. Next slide. So I'll stop here. And, you know, it's important to talk about monkeypox. There's a lot we don't know. There are things we do know. Just because the early infections have been one place doesn't mean that it will stay there. That does not mean that we should stigmatize and isolate and ban folks from our communities. You know, I think we all play a role of kind of being aware of monkeypox. You know, there's some just safe practices out there, you know, around the kind of personal intimate contact. If people have been exposed, you know, really let them know that they have an opportunity to be vaccinated, the vaccines that are available. And again, if you are high risk and you believe that you have monkeypox, stay put, call your healthcare provider, and then go from there. So, you know, at least right now, from a healthcare provider standpoint, we want patients to kind of let us know so that we can prepare to test, you know, so we can prepare to test. You know, if can't get in contact, you just show up and let them know early, you know, so that the appropriate kind of precautions have been kind of taken. And again, from our standpoint in healthcare, it may seem like it's overkill for the precautions, but you know, that's the best data that we have from a healthcare standpoint. With that, I'm going to stop talking and open it up for questions. Brother Malwan, this is the point where if y'all have questions, Brother Sumter and I will tackle the questions. In the chat box, Brother Grandi Gomes has kind of put some links to Cleveland Clinic as well as the CDC. Very reputable resources.
Dr. Rayford and Dr. Sumter, definitely thank you for this informative discussion on monkeypox. I just have a quick question. I know it's mentioned, but can you just cover what PPE is suitable if you think that either whether you have monkeypox or if you are trying to prevent from having monkeypox for other people? You know, like, is a mask, N95 mask enough, especially when you're saying the lesions to skin?
Yeah, so I'll tackle that. I think I may have kind of,
And for adults and kids. I don't know if there's any case, see that in kids.
yeah. So the PPE that I mentioned were kind of more healthcare focused, and so this is somebody that is going to knowingly go and kind of engage the lesions. So if I'm there engaging the patient, engaging the lesions itself. So the PPE I'm talking about is that's what I'm talking about. Everyday life. Everyday life, I kind of glossed over it, but it really needs to be close, continuous contact, particularly contact with the lesions or something that's really been really close. So, like I said, riding the subway, sharing an Uber, shaking hands, all that stuff, a quick hug, you're not likely to get monkeypox through that. So, the general public, as far as like PPE for the general public, there's no recommendation for kind of PPE for the general public. What I will say is, from a sex standpoint, safe sexual practices, kind of barrier methods, but also a recognition that that although we think that sexual contact could be one of the routes of spread, the close contact, so a condom may not prevent you from monkeypox. And so, it may be kind of, more barrier protections. If you look at the CDC site, they really go down the list of ways to kind of, ways for people to take measures to protect themselves, kind of in a very, unbiased kind of way, just kind of really, talking really frankly about, things like sex toys and kind of full body latex and things like that. So, but no recommendation for PPE for kind of the general public.
Appreciate that. Again, you can come off mute if you have a question. Or you can raise your hand, or you can actually put a question in the chat box if you are a shy one.
Well, I guess I'll take the first shot.
Appreciate it.
So I'm hearing the brothers. I get, what was the brother's name that was just presenting? No. No. Dr. Rayford. Okay. So I guess for me, and coming out of DC, we get a lot of this stuff firsthand from NIH, CDC, New England Journal of Medicine. I think what we have to look at, especially as Black people, is we tend to look at things in either let's just take even the most recent pandemic that we had. We thought it was a conspiracy. It wasn't real. Our understanding or lack thereof of viruses in our community, people don't think that viruses replicate. They don't, which they do. They change, they mutate. And I think it's also our community's lack of understanding. And we can even go back to when the 80s happened, when we had a virus called AIDS. And so while this is not to that level, what I think we got to be very, very, very careful of is saying that it's to one community based on a certain group of characteristics or the LGBTQ, because that's very dangerous. Because I will tell you, Dr. Rayford, the CDC is going to probably say to you within the next week or so, that's not accurate anymore. And the reason it's not is because they're looking at the spread in communities being affected. Our community is specifically being affected in that we sometimes don't want to go to the doctor. We don't want to get vaccines. So I would like to really caution us and be very careful about wanting to identify certain communities and characteristics, because the same was said of AIDS, that it was just, and it started off that way, but it didn't end that way. So it is imperative. I'm a big proponent of pushing that we get vaccinated. And it is not, Tuscaloosa or the Tuskegee Airmen. It's been around. It is proven to be effective. I would like to encourage us to use science. It does work. You're in pharmacy. You all went to medical school. I believe in science until it says otherwise. So I will tell you, just from the epidemiologists and those coming out of NIH, which are right down the road from where I am now, I'm seeing a lot of that. But what is interesting is that is a lot of the vaccines right now are only limited to certain groups that are coming into contact. And I wish that would open up. Have any of you brothers that are doctors on this call have availability or no availability of vaccine otherwise? Can you talk to that? Thank you.
Thank you, brother.
Brother Sumter?
You can go ahead, Brother Rayford.
Okay, yeah, so brother, I totally agree with you in terms of like being really sensitive to the stigma, letting people know that just to be really careful about, you know, isolating this to one group. Definitely a lot of nuance, and the CDC has been really deliberate about kind of that nuance of, although this is the group that has been most affected, this is a risk to everybody. And again, as we know, we will learn more 2 to 3 weeks down the road. You are totally right that, you know, our understanding, you know, I think that's our reality here, is we're going to learn about this in real time and being able to communicate in real time what we know. And so you're right, vaccine. So in terms of access to vaccines, I'm in Mississippi. So each state gets an allotment of vaccines, just kind of, it's a little bit population based, at least initially. And then the way the distribution works, and the reason I know is our state has been trying to get physicians, nurse practitioners to serve as vaccinators. We're really trying to make sure that in vulnerable communities, particularly the Black community, uninsured, that they have kind of trusted vaccinators. We've learned with COVID that having trusted vaccinators, so the big government rolling in, that would not work for many communities in kind of where I am. They work other places, but have really kind of led the conversations. And this is just last week conversations about trying to get us to serve as vaccinators. Supply is really limited.
Yeah. Actually, I just wanted to jump in because I just read today that the Biden administration injected $11 million into the monkeypox vaccine production. So that was, I thought, good news that just came out today from, you know, 11 million. So.
Yeah, so one thing about the vaccine, so a couple things about the vaccine. Right now, the preferred vaccine is only made by one European company. And there's supposed to be tens of millions more doses on the way in the next few months. There's been a change in how the vaccine is administered. That change means that more doses can come per vial. And so it's a change that's kind of meant to try to reflect. I will tell you that a lot of what we're doing has not been studied in the way that we like things to be studied. We like things to be studied in what we call randomized control type things, with the speed at which things have happened, and the urgency means that we're using things based on similarities to smallpox. There is another vaccine that's more, the supply is more. There's more that if we got to it, we could use that vaccine, although it's a vaccine with a lot more side effects. And so it's probably not the preferred method in a population that's becoming more kind of, you know, vaccine tired. Vaccines are excellent. Vaccines are still going to go down and saving more lives than antibiotics and kind of other modern medical things. But the supply is short. We are hoping that we can get a lot more. But Sumter?
I was just going to concur with what you said, Brother Rayford, as well, on that those who are interested, who are either exposed to someone with monkeypox, you know, as I think Brother Gomez also alluded to, we should definitely get vaccinated so that we can help stem the spread of monkeypox. There's a comment in this section, and Brother Melwan, could we go to the, there's a question about.
The question was, it was mentioned earlier that a mother can pass it on to her unborn child. I would like to know if it can be passed from a mother to an infant via breastfeeding.
Yeah, and so I was just looking that up just now. Yeah, so the main way that monkeypox is spread is from skin to skin contact, direct contact. But it is also recommended that because infants, neonates are at they're a vulnerable population of individuals, and they're at a higher risk of having severe illness if they happen to become infected with monkeypox. It is actually recommended that breastfeeding is delayed in individuals who are infected with monkeypox to reduce the likelihood that that mother's infant, neonate, will become infected with monkeypox through breast milk or skin-to-skin contact, and then thereby develop severe illness. So it's recommended that mothers avoid breastfeeding while they're infectious. It's recommended that they avoid breastfeeding until their rash is completely healed, the scabs have fallen off, etc. Until they can come out of the isolation period, it's recommended that mothers who are breastfeeding avoid breastfeeding their infants.
Thank you. Is there any other questions? Feel free to raise your hand or come off mute.
Yep, there's a hand. Let's see. That's going to come off mute.
All right.
Hey, I had another question for somebody in the room, for the medical professionals in the room. With the other thing that I've been reading, like in the New England Journal of Medicine, is a lot of this is not just the pictures that you show, but the after effects. I read about it being disfiguring. Does anybody know anything about that, or can elaborate on that?
Yeah, so that's actually a great question. I don't know a lot about the kind of disfigurement, the disfigurement part after the infection. Don't have any experience kind of in our area with it, but that'll certainly be something that I'll look more into in terms of the disfigurement. I will say that a lot of the knowledge that, a lot of our experience historically with smallpox is influencing how we're beginning to approach monkeypox here. I do know that smallpox can be very disfiguring. If you've heard of the word pox marks or pock mark, those can be those kind of deep-seated, healed, kind of residual skin lesions. And so there is certainly a possibility for skin disfigurement, particularly with the most extensive and severe diseases. It's just being able to get you to come up with the exact number. I think in the next week or so we'll have a good sense of that. The challenge is, for 2 to 4, maybe longer, 2 to 4 weeks, you have a rash that you expect to get better and go through the healing process. And so, we expect in another 2 to 4 weeks to have a significant number of people who are 4, 6, 8, 12 weeks out from their initial infection, so that we can look at the skin disfigurement from.
Dr. Rayford, one more question.
Yes, sir.
I'm sorry to monopolize time, brothers. I just wanted to ask some medical questions. The last question I have for you: is this virus similar to like when you get chickenpox, which is a variant of the herpes simplex virus? Does after this, does it stay with you, or will it come back? That's
I think that's a perfect question. It's, although pox is similar, it's not in the same family as the herpes viruses. So chickenpox is herpes viruses. Those viruses have a tendency to go live in a nerve root and kind of reactivate itself like shingles. So chickenpox to shingles. What we know, and again, we're extrapolating our experience from smallpox. We haven't seen, historically a recurrent kind of thing. So a smallpox equivalent to the shingles infection. It doesn't seem like the smallpox. Smallpox is bad because it killed up to 50% of the people. And so we have not seen that neural reactivation kind of thing that we've seen with chickenpox. And they're in different families. They're both DNA viruses, but the orthopox viruses are much bigger. And they're much bigger, and smallpox is kind of closest kind of cousin that we have experience with, but it doesn't seem like there's a years out from it reactivation. And again, we have, unfortunately, I think this highlights kind of where this disease has been going on, but because where it was in Africa, Central and Western Africa, it didn't have the world's attention, and now it does. And so there's a lot of stuff that we could have known right now based on paying attention to monkeypox in 2000, in 2003 particularly. Paying more attention, we could have had 19 years worth of experience to what happens to monkeypox 19 years out. Those people in the US, what happened, to monkeypox. And so, we're going to pay attention now to kind of new viruses. And our new reality is something that's going on in any part of the world could be very relevant to where we are. It doesn't matter how remote it seems. But thank you, brother. Thank you, Brother Gomez.
Thank you, Fred.
All right. Brother Eskridge, you go ahead and unmute.
Yeah, I had a quick question I was curious about because a couple comments was made about smallpox and then about the vaccine. I remember back in the 70s, if I'm not mistaken, because I was born in 71 and was vaccinated against smallpox. Does that have any effectiveness against monkeypox, or are you talking about a different vaccine that's created now that hits smallpox? In other words, I don't know which vaccine it was because I was a kid, is what I'm saying. I don't know if it was made by this company, made by that company. I don't know. I just know it left a circular mark on my arm. That's all I remember. Yeah. So I was just curious, does that have any type of effect against what we're dealing with now with monkeypox?
Yeah, so that's actually a great question. And if you were vaccinated 30 plus years ago, it may not be as protective. Recent vaccination against smallpox, places that recently vaccinated, yeah, I mean, that's actually the strategy that we're doing. So we're using the Jynneos vaccine, and how it differs from the one that you probably had. So if you had the smallpox vaccine there, we typically think of vaccines as one single needle, and it goes into the skin, mostly deep into the muscle, where you inject the part that the body needs to react to. So the smallpox vaccine was one where you actually irritated the skin with a virus that was similar enough to smallpox. It'll cause like a local reaction, and you end up with this scar. So you can have this, people who've been vaccinated with smallpox, there's usually a dime-sized area where they were inoculated. And so the versions that are out now are the viruses are the kind of the preferred virus is one that has been significantly modified to not cause as much of a local kind of reaction and to kind of have less side effects. The one that's more widely available uses a similar method to the way you got vaccinated, where you take kind of like a multi-pronged needle and you kind of generate you kind of inoculate the skin, and you count on there being a more local reaction. And so, but that virus is a lot more active than the other ones. It's still better than smallpox, still better than monkeypox, but those are the strategies that we have. And again, we still have some more to know about the long-term effects of smallpox vaccination. I don't think it's going to be as protective, but recent smallpox vaccination is protective. And that's the strategy that we're actually using. Brother Sumter, so I actually have a question for you. Where I am in Mississippi, we've been getting the info to kind of prepare, to be ready, to respond, to kind of be, to be ready. But doesn't still feel we have cases of monkeypox in our state. We don't really know what parts of the state's affected, but it still feels like it's not here yet. How does it feel in South Carolina?
Very similar. Like we know that it's emerging, but we don't have a huge number of cases here. And it's still something that still kind of new. I don't think reality has set in for a lot of people, but it's on the radar. People are talking about it, and people are and I've been encouraging patients of mine who are like high risk. I say, hey, you may not want to engage in certain activities, but also caution people to say, as you mentioned before, and as Brother Gomez was alluding to, that this is not just a virus that can impact only one population of people. Because actually, the two individuals that I definitively know that I tested positive for monkeypox were actually female. So one was like in her mid-30s, another one was like a teenager. So yeah, so that highlights that this virus can impact an array of populations of individuals. But because the number of people locally have been infected have been low, it's still not as widely talked about as people were talking about COVID, so forth and so on.
We have another question by Brother Williams. And he wanted to say, he's asked, can we look at the titers? I hope I said that right, titers for smallpox.
I think that's a great question. I don't know. I think that's one of the questions that we will know more about as time goes by. Particularly how we would potentially know that is if the transmission continues and if we notice that there are groups that just don't have it despite it being prevalent in the community, we may then take that second look and say, hey, what about this group is protective? And that might bring us to, now the challenge is when it comes to titers, what we've learned with COVID is, there were times we're checking for COVID antibodies, but the reality is we couldn't settle on the right way to test for antibodies. And so you had so many different tests that were offered up and weren't necessarily sure about how valid or valuable it was. I think we're going to have to go through that phase as well, that we're also going to have to know the optimal test for monkeypox immunity. We're going to have to know the optimal test for smallpox immunity. I think, I will say that smallpox is a success story because it's the first and only virus that we have been able to say that we eradicated it. And that was through vaccination. And it was done in a way that my parents got the smallpox vaccine so that I didn't have to. So smallpox wasn't a vaccine recommended when I came around for my vaccines.
I'll echo, hi, it's Andrea Stevenson. I'll echo that a little bit and just say, I think that's a great question about the titers. One thing you have to think about is when diseases have been eradicated, laboratories sort of stop making, tests to detect the antibodies, because we as healthcare providers and clinicians, until very recently, we said, oh, smallpox is not something that we have to deal with. And so therefore, resources and attention, research, et cetera, get focused on other things that are that we view as more relevant. But I do think eventually, as we sort of see what the course of monkeypox is going to be, then that will be something that is developed probably relatively soon. And echoing again about the titers for COVID, not only was it difficult to detect having antibodies to certain parts of the virus, those are present, but are those antibodies protective or are they just present, So there's a lot of nuances there, but I do think that was a great question.
So Dr. Stevenson, thank you for joining us. Could you tell us about kind of monkeypox in your area? what area are you practicing and what's the
I
experience?
can. I was trying not to interject too much. So yeah, so I practice in the DC metropolitan area. And so as many know, right, we have the highest rate per capita. So not the highest rate, but the highest rate per capita. That in part is due to, you know, the demographic that is affected by monkeypox. And just the fact that we have a large percentage of men who have sex with men in DC. I myself have not had a patient, not yet, but I'm waiting for every day, come into my office with monkeypox. I have had a few gentlemen who have come in who have been concerned about monkeypox, but have not actually had the infection.
And so so you've been able to, so thank you. I mean, I'm glad to have your perspective. So you've been able to test, and as far as your experience with testing, you know, did you find any challenges with testing?
No, so testing for monkeypox is very similar to testing for like herpes or shingles, right? That you would unroof the lesion and then collect a culture there. And then you would want to get at least 3 locations. Typically, when folks have monkeypox, there are multiple lesions to choose from in various stages of healing. So you just want to unroof and use essentially what is going to look like a Q-tip, right, to collect some of that sample.
Thank you. So there's another question in the chat about have they seen cases of monkeypox in patients with underlying health conditions like uncontrolled diabetes?
That's a great question. I personally have not seen monkeypox in my office, but I would imagine so, right? Because when you have uncontrolled diabetes, you are immunosuppressed. And I would imagine that the extent of the monkeypox infection and the lymphadenopathy that occurs would be quite a bit more in the setting of uncontrolled diabetes.
Yeah, I agree with Dr. Stevenson. I haven't had a patient with monkeypox and diabetes, but just intuitively what we've seen with COVID, patients with underlying medical conditions such as diabetes and other chronic diseases, they tend to have more severe disease or symptoms of COVID. So I would imagine it would be the same with or similar with monkeypox infection.
And I'd like to add that, you know, we don't necessarily think about this group of patients, but it's very relevant for monkeypox. So people with skin diseases like severe eczema, psoriasis, and so diseases that tend to affect large parts of their skin, they are at a unique or heightened risk for monkeypox, male or female. And so these groups are people who are, you know, they're considered high risk. I'm also pediatrics trained. Eczema is really common in pediatrics, people who are very allergic. And so people with widespread, you know, skin disease anyway, unfortunately, there's a lot of stigma already. They're also a group that's at risk for stigma, people with skin lesions, but they're also a really, really vulnerable group. And so that's a group to think about as we're thinking about, you know, who's vulnerable outside of the group that was originally described. That, you know, that vulnerability can extend kind of down those kind of pathways, and you know, we worry about those. In fact, in terms of the medication for severe disease, people with severe eczema are actually ones that we are encouraged to use that medication for if they were to come down with monkeypox.
That is great dialogue. Definitely appreciate you, Dr. Stevenson, for jumping in there. Anytime we can get another or multiple doctors nerded out on monkeypox, I think it's a great webinar. So I definitely appreciate that. Does anybody else have any other questions? These are great information. Anyone else?
Can we get any copies of these slides?
Of course, my brother.
Yes.
And the video will be posted on our YouTube channel under the social action videos. So make sure you subscribe to that. Shameless plug to the IHQ staff who handles and does a great job with that. All right, well, if you don't have any other questions, we'll give them back about 10 minutes of your time, Dr. Sumter and Dr. Rayford. I definitely appreciate you guys coming on and sharing your knowledge and with the community that we serve about monkeypox and what we should do. And I know, like we had talked about it before as we were planning this webinar, that this is something that we're going to have a continuing conversation about, because I'm sure it's going to have some kind of COVID underlay as well. And so as we continue these kind of type of conversations, I think it's great that we have resources like you good brothers to come on and share it with the public. So I'll let you guys close it out. Thank everyone for joining. Dr. Rayford, I'll turn it over to you.
Okay. So I just want to thank you for your attention. Again, we'll be back. We'll be back to just talk about what we've learned in the time period. Kind of be aware, take monkeypox seriously, but also don't lose sight of COVID and everything else. Brother mentioned polio. So, unfortunately, we're seeing a resurgence of things that didn't necessarily get kind of the main focus in medical school because we thought that we moved beyond those things. But so be aware, be alert. Vaccines are typically the best recommendation. Vaccines have saved more lives than almost any intervention. Clean water and vaccinations. But again, kind of be on the lookout for more discussion. We look forward to coming back to talk about a different aspect. I would love, and we're working on it, I would love to have brothers who are veterinarians to talk about it from the kind of, from the kind of animal perspective. And again, they have a role in this as well, again, because we don't want monkeypox to be, we don't want the United States to be a regular place where monkeypox lives. And so there is a need for us to really think more than just beyond human spread, think human to animal spread as well. So, and Brother Sumter, I'll let you close out. I really appreciate sharing the screen with you. Look forward to more talks in the future.
Thank you, Brother Rayford, Dr. Rayford, and also Brother Melwan for this opportunity to partner with you all to share information with everyone on this webinar tonight and those who are going to view in the future via our YouTube channel as well. Information about monkeypox. It is my hope and my prayer that everyone take this information and share it with others so that others can be empowered with more knowledge so that we can work collectively to stem the spread of monkeypox. I just believe that when we know better, we will do better. And so knowledge is power. Knowledge can empower us. So so it's my prayer that this webinar has been informative, empowering for all. And I hope others join us on future webinars as well.
All right. Thank you all. God bless. Have a good night.